It's my pleasure to start the key session on this surgical site infection, where we are today. Such a question mark at the end. And it's my pleasure to introduce our very first speaker, Professor Finn Gottrup from Denmark, and he will be speaking about what are the known mechanisms of surgical site infection and which factors are responsible. Yeah. Please, Finn.
Thank you. Can you hear? Yes. I'm only giving a short introduction, and it's also always boring to be in the last session of a congress, so a lot of people has disappeared, but I think we are pretty happy that still is some left. What I'll go to say a little is about the introduction of the topic of surgical site infection. I'm coming from Copenhagen and from a Copenhagen Wound Healing Center. The content of my short talk will be definition, classification, diagnosis, incident, mechanism, on which factors actually are influencing, and then short recommendation, what we're doing. Definition, classification. A definition of surgical complication in general is a disturbance of the normal healing which results in a delay or no healing at all. It's a very general one. If we are talking about infection, especially acute infection, surgical site infection, we have a classification, a classification here which actually is that you have superficial surgical site infection, you have deep, and you have organ-spaced. I would say this one probably is 90% of everything. It's the superficial one. And that's the reason Center of Disease Control and Prevention has made this superficial actually diagnosis, what it is, purulent drainage, positive bowel culture, and so on. I will not go in detail with that. And all these things should occur in 30 days after surgery. This is a very general classification. What about the diagnosis? It's the same there, very simple one. You have diagnostic abscess, cellulitis, necrosis, and the symptom is all the inflammation symptoms. Redness, secretion, pain, warmth, slough, and so on. Acute wound, fortunately, is much, much easier to diagnose than a non-healing chronic wound, because it normally looks like this. It's rather easy to find out that there is an infection in this one, and it has all the classical one here. But what is the incidence? And I use this a little old slide, because actually the incidence almost is the same today. Before we used prophylactic antibiotic, it was very high, especially in case of infected area. If, for instance, abdominal surgery, you have infection, up to 40% SSI, superficial SSI, in this case. But after we have introduced prophylactic antibiotic, it has decreased. And you can see it's referred about 20, 25 years ago. But still, I must say, if you have a dirty wound or infected wound area, then you still have almost 10%. I think David will show a little more about that. But depending on where you are in the world, there is very big differences. Because this is some years old, but I was just at a meeting in India, and they published this, one of the biggest hospitals in England and in India, and they are actually private and very well driven, but still hospital infection was 10 to 15% of all patients admitted. That's a lot because of the lack of hospital hygiene and sterilization procedures. And this is a well-driven hospital in Mumbai. So it can be very different where you are. What is the mechanism of infection? Then you have to look at this one. Infection is a balance between bacterial load, virulence, and host resistance. And I'll go a little into some of these things and define what we are finding here. But it is a balance between the bacteriological factors and the host defense mechanism, including antibiotic, antiseptic we are doing. What is the mechanism? As I said, microbiology factors, patient-related factors, technical surgical factors. Number of bacteria. It's an old one because it's a very old slide again, because there is a direct correlation, more and more bacterial density, then higher and higher wound sepsis. It's a totally clear correlation that way. So bacteria number is important. What about the virulence? And that's only the thing I have learned from one of my best friends, which is a professor of microbiology. You have different types of bacteria in a wound, and we also talk about the chronic wound now or non-healing. You have invasive, you have local bacteria, and opportunistic one. This one is bacteria which normally not giving SSI, but can give it if you have a foreign body or so on. But I'll only focus in this short introduction in the invasive one. And the invasive one means that you can put the bacteria on intact skin and it will actually invade the tissue underneath and give an infection. And there we have, especially related to this type of wounds as eye and also chronic wound, hemolytic streptococci, group A, C, D, so on, and staphylococci. That is the two main things you can focus on. And there is a big difference in how dangerous they are. He learned me that, my friend, as I said. If we are talking about streptococci, we are very much afraid of this bacteria. Why are we that? Because all bacteria produce a lot of virulent factors, enzymes and so on, but they are producing streptolysin and streptokinases. And streptolysin and streptokinases is actually the two one we dissolve the embolus in the cardiac vessels today. They're extremely strong. That means that they can spread. If you have a streptococci infection, they will spread from day to day or from hour to hour. You can see we have marked it here, and it will spread directly. So it's extremely, extremely dangerous to have this type. What about the staphylococci then? The staphylococci, of course, also have virulent factors, but the strongest part there is coagulases, which is much weaker than the two others we have shown here. That means that the staphylococci normally produce abscesses, localized infection. It's not very nice when an abscess, but still it's much, much less dangerous than the streptococci where it spread directly out. So staphylococci primarily produce abscesses, like you can see here, and it's not very nice, but it's not as dangerous as the other one. So that means if you have a chronic wound, especially with low perfusion, and you have a streptococci there, you have to be extremely careful because you very easily lose the leg. What about the resistance of the bacteria? We know that, we have talked about that for a long time, and I have this map on MRSA, and if you look at Europe, we can see where we are today. Here the color is red, meaning that you have 25 to 50% of all your staphylococci is MRSA. But if you're looking at, for instance, where I'm coming from, Denmark, or Scandinavia, you can see it's lesser than 1% still, or about 1%. That means we can isolate our patient with MRSA, but if you have half of the patient have MRSA, you cannot isolate them. So it's much more difficult actually to combat that. But also resistance is developing for other type of bacteria too. Which type of influencing factors is going on? There's a lot of them, but I will only focus on a few things we have been related to: the hemodynamic conditions, tissue perfusion, tissue oxygenation, and smoking. But you can see there is a lot of factors which actually influencing both healing but also infection. And oxygen and infection, systemic normal baric oxygen. We're not talking about hyperbaric oxygen. We made some studies. I was part of that back in 1988. If you can see how much resistance an organism or tissue have if you inject some bacteria, and you can see the necrosis around. You can see if you are in normal air, 21% oxygen, then you have this type of abscesses. But if you are in hypoxia, low oxygen, you have much more abscesses. And if you give extra oxygen, then you have very little abscesses. And that was actually something has been used since then. In another way, you can also do it in guinea pigs. You can inject E. coli in this case, and you will see if it's a hypoxia, very big, the y-axis actually is the necrosis, very big necrosis in hypoxia. It will become smaller if you actually give ampicillin. That's clear. If you give antibiotic, it will be smaller. But the same effect without antibiotic you can have with raising from 12 to 21% oxygen. And the key point in this experiment, which is old, was if you gave both antibiotic and oxygen, then you couldn't make abscesses on this. And that was actually what was happening in the year 2000. New England Journal of Medicine asked me to make an editorial on that, and if you is asked by New England Journal, you know, not saying no. And they have an investigation where they have had two groups, where they actually, in one group, very comparable, it's colonic surgery, and they have given extra oxygen during surgery and 2 hours later using a mask. If you have done, in this case, you actually found that the infection rate, SSI, decreased from 11% to 5%, only giving this short time of oxygen. So at that time, there was a big discussion on whether you should do it. Unfortunately, today, it's the way that we have 3 major studies saying good effect, but we also have 2 studies in JAMA now which saying they can't find so good effect of that. But still, I would say I will give my patient actually oxygen because it's very cheap. You are in the recovery room 2 hours later at that certain recovery room, and you can very easily put on a mask. So I will do it, whatever it is. But it's not, I have to say, it's a big discussion yet. What about smoking then? All the thing which is very nice is also dangerous, unfortunately. And oxygen, in this case, we find out smoking by itself decreases oxygen in the tissue. If you measure oxygen subcutaneously here, and you are smoking 1 cigarette, this study showed that in almost an hour, your perfusion and oxygenation will be decreased with about 30–35% in an arm, for instance. So it's really important that so we did some studies, and in this case was wound healing we talked about. We have 14 volunteers, non-smokers and smokers, young people, 28 years old, totally healthy, and we compared them, and we found that the collagen production, if you are smoking 20 cigarettes a day, collagen production is decreased with about 60%. So the old term that the plastic surgeon said, if you're smoking, you're not healing well, is shown by this, because this one is a human model. We have used the small vascular prosthesis put in, taken out 10 days after, and analyzed for collagen. So it's in human we showed this. But another thing, another doctor I was working together with made another study. We had another model here where we actually have a biopsy in volunteers. And after 1 week, you can take a biopsy out, you can cut it out, and you have a small scar with about 1 centimeter, a wound about 1 centimeter. And then we realized during that time that some of them get infected. Again, it was young people, totally healthy. They should not be infected with that. And then we made a randomized study, which actually came in Annals of Surgery, and found out if you are a smoker, you have between 5 and 6 times higher risk of SSI postoperatively. You have bad wound healing, and you have much higher risk of a surgical site infection. And we also found out it's not the nicotine in the smoke which is the problem, because nicotine patch doesn't have this effect. And to get this away, this effect away, you need to stop smoking 4 weeks at least before elective surgery. So that is the reason, this 2 human study is the reason that the Danish National Board of Health have now recommended that we stop smoking 6 weeks before elective surgery. You have to do that, otherwise you're not safe. We are not safe. 6 weeks is not enough for the wound healing, but it's enough for the infection, so they have chosen 6 weeks that way. But in spite of that, many of our patients in our center still smoke whatever, even when we have solved it. Technical factors: prophylactic antibiotic, preoperative preparation, foreign bodies, laparoscopic technique. I will shortly go through a little of this. Preoperative prophylactic antibiotic. Used in abdominal surgery, orthopedic surgery. Single dose, except maybe for very high blood loss or surgery more than 2 or 3 hours. Against present bacteria, once you do actually inject this preoperative prophylaxis before start, you should not give it just before. It has been investigated. It's better effect if you give it half an hour to 1 hour before surgery start. So it's not just before. It's best from 30 to 59 minutes before you start surgery. What about discussion we have had so many times, preoperative hair removal? There's no risk, no reduction of risk if you remove hair. Absolutely not. And if you really feel that you have to do it, use a scissor. Don't use a razor, because then you open the pores and a lot of bacteria come out and it raises actually the SSRI. And it don't matter whether you do the operative day or the day before. So preoperative hair removal is not a factor. Perioperative factors, laparoscopic technique. Has laparoscopic technique actually decreased the infection rate postoperatively? Yes, it has. We have made some of the major studies done in this area has been evaluated this way, and all of them is falling on this side, which is in favor for laparoscopic technique. So at least looking at the wound infection, it's going down if you use laparoscopic technique. Foreign bodies, I have a very suture strain message. Does that mean anything? Absolutely. This is a very old study from back to 78, actually. But it's a very good model they have used. They have taken a guinea pig, as you can see, put in so many bacteria that the wound was heavily contaminated. Very little should change it before it actually gave pus. And you can see here, then they made a wound and put on a loose suture there. And you can see, actually, if you have no suture, you have 25% of infection. If you have a loose suture in there, 100%. Then they say maybe we should close the gap in the wound, so we actually, like we do in the subcutaneous tissue, put in the wound loose, and then we closed it by the suture. No difference. A suture is a foreign body. The risk of infection is always higher. You need to have an indication for using. That's the reason we normally not using sutures in the subcutaneous tissue, because the subcutaneous tissue is very less perfused in that way, and the risk is high for infection. Then also suture material, we made a study on other things where we compared actually Dexon, which is multifilament, and then Maxon at that time was monofilament, and we found there was no difference in a lot of other things, hernia 1 year after, but wound infection, there is a difference. Multifilament sutures is giving higher wound infection compared to monofil. Again, drain. We tried different type of drains we put in. Drain is a foreign material. If you have no drain, about 10% of infection, 100% if you have a elastic. Then we took a LASIK drain, the same thing. It's foreign body. It don't matter which type of material it actually is made of. So in some way, drain has to be there for a purpose, but taken out as soon as possible. The risk of infection is there. So finally, the recommendation based on what I have said, avoid cooling and smoking, use supplementary oxygen, observe blood saturation. I haven't said that about that. Prophylactic antibiotic, gastrointestinal intervention, orthopedic. If you have a contaminated tissue or a foreign body, also use prophylactic antibiotic, and use laparoscopic technique if it's possible. So my conclusion is infection is most critical complication in post-operative wound healing. Collaboration with a microbiologist is a key question, and last and good quality trials is still needed, so on. And maybe all our recommendations may be changed if we get more and more multi-resistant bacteria. I think so in the long run. Thank you very much.